we talk about the laser treatment in glaucoma. So let's make it very simple. We divide it as for open angle glaucoma and angle closure glaucoma, right? So when you say angle closure, we have discussed so many times, it is peripheral iridotomy by NDR. And a very important exam question, earlier also mentioned, we should always do a prophylactic peripheral iridotomy in the other eye. Let's not forget that. So it means even if the other eye is not suffering from attack of acute primary angle closure, we have to do a peripheral iridotomy in that eye as well, right? So in other eye. We come to the next important point. For angle closure, if it is a plateau iris, we all know peripheral iridotomy is not effective at all. So in that case, we go for iridoplasty, right? So when you say laser iridoplasty, we are giving peripheral burns at the plasty. Again, we will use photocoagulative laser. So what we are doing here is that we are applying the laser at the periphery at the iris. So this is this is the iris, right? So when you apply the laser here, what happens? It contracts and opens the angle. So because it contracts right now, iris contracts and opens the angle due to these photocoagulative laser burns. So that was about angle closure. We talk about open angle. Open angle, so main problem, blockage in the trabecular meshwork. We go for trabeculoplasty. Now when you say trabeculoplasty, what is happening actually? That when we are plasty, again we are applying photocoagulative laser, it increases the intermeshwork distance. Okay, so what is the mechanism? It increases the intermeshwork distance, trabecular meshwork distance. You understood? So if these are the TMs, suppose, so some TMs will open, the channels open because of that, and therefore the outflow will open. You can do the trabeculoplasty by 3 different ways. Either I can use argon laser trabeculoplasty when I am using argon, correct? We all remember the wavelength, 514 nanometers. Or I can go for using the selective laser trabeculoplasty. We use double frequency NDR. We go for double frequency NDR, right? That is 532 nm, half of the NDR, right? Then third, we have another modality, MLT. What is MLT? This is micropulse laser trabeculoplasty. Okay, so micropulse laser again, micropulse laser trabeculoplasty, we are giving in a very, you understand? Very short duration. It's a micropulse. Okay, generally it's a micropulse diode. So this is micropulse laser trabeculoplasty. In this, of course, we don't get a tissue reaction. It is only the purpose is to stimulate the cells in the trabecular meshwork. So these are the 3 modalities for trabeculoplasty. Okay, simple. So that was about laser treatment in glaucoma. Can we also think of anything else? One more important. How will you manage absolute glaucoma? I discussed with you, damaging the ciliary processes. What do you call that? We call it cyclophotocoagulation. So it can be either this cyclo means on the ciliary body, right? So this cyclophotocoagulation, I am either doing it with the cryo, or I can go for laser. Which laser? It is generally DLCP. This is diode laser cyclophotocoagulation. So we are using diode 810 nm. Right? Then we talk about is, you know what is the mechanism, why we are doing it. When we damage the ciliary processes, the aqueous form less. So generally we are doing it for absolute glaucoma, or in case of any refractory glaucoma, which is not responding to your medical therapy or any other form of treatment. So refractory glaucoma, like we would say, sometimes can happen after neovascular glaucoma or malignant glaucoma. We have learnt about all this. So just any cause of refractive glaucoma. So the refractory glaucoma. So that this is the indication for cyclophotocoagulation. Also understand that this cyclophotocoagulation, it can be done either endoscopically, okay, or I can do it over the sclera, that is called transscleral. Okay, so either I can do transscleral cyclophotocoagulation through the sclera, this stands for transscleral, or I can go for endoscopic cyclophotocoagulation. We'll see the slides after a while. So I think this is clear. Next we talk about is surgery. When we talk about the glaucoma surgery, we can divide it into one which is a penetrating type, which means I am entering the anterior chamber, or it could be non-penetrating where I am not entering the anterior chamber. Okay, so when I say penetrating, it is I am making a connection from the anterior chamber to the subtenons or subconjunctival space. So we can learn it in this way, that penetrating, what we will discuss here is trabeculectomy, right? And we will also talk about minimum incision glaucoma surgeries. Coming to non-penetrating, we can learn like this, two main things that you have to know. So in non-penetrating, one method is called deep sclerectomy. When you say deep sclerectomy, what does this mean is, we are making actually two scleral flaps. We will remove one deeper one, but not the superficial. So it's like not entering the anterior chamber direct. Second you can do is, you can just dilate the Schremm's canal through viscoelastic. That is what is called viscocanalostomy. Okay, so just know the names. I don't think they will ask you any details here, right? So viscocanalostomy. Peripheral iridotomy has been an exam question. They can ask you about trabeculoplasties. They have asked you about cyclophotocoagulation. Cryocyclo is the treatment of choice for absolute glaucoma. I have discussed that question already. Next question that they have asked you is more about trabeculectomy. But yes, we have to know everything. So non-penetrating, know the names. Viscocanalostomy, where you're dilating the Schremm's canal through the viscoelastics, or deep sclerectomy. Okay? Okay, so once we know this, we next talk about is trabeculectomy. What is trabeculectomy? Very simple. Let's first make the diagram to understand that when I am just this trabecular meshwork, I have drawn this diagram so many times for you all. I am removing this. What am I then doing? Creating a direct connection from this anterior chamber, right, to the subconjunctival space. Got it? If you want to understand from the different perspective, we can make another one. So if this is your eye here, what is trabeculectomy is making a direct connection between the anterior chamber and subconjunctival space. So this time I am cutting the block of the trabecular meshwork here and creating a fistula between the anterior chamber and this. Why do you call it subtenons or subconjunctival space? Because we are covering it with the flap of conjunctiva. We'll talk a detail about it here. So subconjunctival space. Just make the diagrams first and then let's write down. What is trabeculectomy? I'm speaking. Resection of TM. If you have understood this, now you can write it. It's a resection of trabecular meshwork and creating a fistula between the anterior chamber and subconjunctival space. So resection of the TM and creating a fistula between anterior chamber and subconjunctival space. So what do we do? What do we do is, once you have dissected you have first, for what you have done, you have raised a flap of conjunctiva. Try not to buttonhole it. And once you have done this, you have to just dissect all the tissues that is below it, that is your episcleral tissue and all, and you have a bare sclera in front of you. On that bare sclera, what I now do is I make a partial thickness V-shaped cut. It's a partial thickness cut on the sclera. So I'll reach a depth, I keep dissecting. When I reach at the angle, I see grayish tissue. This is the TM which I am going to cut a block of it. I cut a block and hence I am creating a fistula. I cut a block by Kelly's punch, and once I have cut the TM, I am going to repose the scleral flap back and I should loosely suture it because I need a leakage from the anterior chamber to this space. Okay? I'll repeat. V-shaped partial cut, kept dissecting, reached that angle area, cut a block of TM, okay? And of course, don't forget, whenever we are inside the anterior chamber, we don't want any factor of pupillary block ever. So we do an iridectomy as well. And after doing that iridectomy, put the flap back. And after putting, loosely suture it. Okay. And at the last, after doing all this, what am I going to do? I'm going to cover the whole thing with a flap of conjunctiva. So because I cover with the flap of conjunctiva, do you realize if the fistula is working and there is a free flow of the aqueous hair, under a small, very thin membrane, if the fluid is flowing like this, is it not going to raise like this, like a blister? So this raised part of the conjunctiva, like a blister, this is what is called bleb. Got it, all of you? So this is what is called bleb. That means presence of bleb postoperatively is a sign of success of the procedure. It is a sign of success of the procedure. Now, any fistula surgery, even if you're the most competent surgeon, there can always be problems. So, how to prevent closure of fistula? Two very important methods. Either I will use anti-mitotic drugs. Now, this has been your exam question. Which anti-mitotic drug? Make a Q there. We will learn two antimitotics that can be used in trabeculectomy: mitomycin C and 5-fluorouracil. Apart from that, what I can do? I can go for aqueous drainage implants. Right? So when I'm putting an aqueous drainage implant, right? Okay? So all these glaucoma drainage devices, we can call it GDD, or you call it sit-in surgeries, right? When you're putting these devices. Now, something more about these drainage devices. One type of drainage device you should know is your express implant. So this express implant or express mini shunt, I can put, like I can just, in this surgery, I don't need to cut the trabecular meshwork as well through a punch. So it's like a modification of the trabeculectomy surgery where I'm just putting a needle, okay, instead of creating a punch. This is used to enter, needle is used to enter the anterior chamber. So this is your express mini shunt. And so not using punch, number one. And another variation from the surgery, so this is a variation from the surgery, no PI done. Anyway, if you don't want to remember this, it's okay. These were some extra points. Please remember express mini shunt or express implant. Now, there was a question here for you all. What is it made up of? So, many places it is written stainless steel, but I think now the new edition of Kansky says titanium. So, we will learn titanium. It is made up of titanium. Right? So, that was about number one. What are the usual standard implants apart from this mini shunt express implant? So, give the heading second, other standard implants. What do you want to learn here? In this, very important is Ahmed glaucoma valve. Okay? AGV, this is Ahmed glaucoma valve. Stands for Ahmed glaucoma valve. Okay? And just remember, this is one old name which was very famous, Molteno implant. So in all these, what are these made up of? Mainly silicon and polypropylene. The plate is made up of polypropylene, plate polypropylene. Easy to learn, P for P. And the tube is made up of silicon with silicon tubes. And remember, it is a valved implant. Earlier generation implants were not valved. So what was the problem here? Too much of drainage, creating hypotony and complications of hypotony. But with this, the next generation implants like Ahmed glaucoma valve, which is the new one, we have a valve. So as soon as the pressure reaches 10, the valve will close. We don't want a pressure less than 10. 10 to 21 is the normal pressure, right? Yeah. Then we talk about your MIGS. So when you say minimal incision glaucoma surgery, we can divide this as So first of all, also understand these surgeries are mainly you can do for mild and moderate glaucoma, okay, where the target pressures are not very high. You have a target pressure of modest target pressure, so I can manage with these surgeries. Number one. And second, very important, so if you write down, it is mainly for mild to moderate degree of glaucoma with modest target pressures, right? One important point. And second important point that we have to know here is that this is mainly done and commonly done in combination with phacoemulsification. Okay? Great. Now, we can divide this MIGS in two ways. Either there are surgeries where there should be no bleb formation or with a bleb formation. Let's divide it like this. When we say with bleb formation, what is the implant? Here we will use Zengel implant. Zengel implant is mainly made up of gelatin. Okay, so this is mainly where do you place this? This is placed subconjunctivally. So this is placed, so it is actually encouraging a subconjunctival drainage and bleb formation. So it is placed subconjunctivally. Done? Now coming to when you say no bleb formation, what are the options? So these implants, first very important, eye stent. You know, it is one of the smallest implant in your body. I'll just show you the slide. So just write it, eye stent, or it could be eye stent supra. So eye stent is actually, these are bypassing the trabecular meshwork and in the Schen's canal. Opening in Schen's canal. Whereas eye stent supra, it opens in suprachoroidal space. Just one line for each, just to know, be familiar with these terms. Then be familiar with another term, hydrus. Again, it is in the Schen's canal. Okay, and one more I am giving you just the name. It is CyPass microstent. CyPass microstent. Right? So this increases generally the interesting point. It increases the uveoscleral outflow. So it increases the uveoscleral outflow. Right? So just be familiar with the terms. This is what we need. Okay, let's have a look at the slides. Okay, so when you look at the slides, you see this is your trabeculoplasty where the laser is actually, ideally it is mainly given in the pigmented part of the trabecular meshwork, right? Reason being it will absorb more energy and will be more effective. Okay, so anyway, at the TM, then second, what are you seeing here? This is how a cyclocryotherapy of cyclophotocoagulation is done. Okay, so, right? And of course, we have discussed this already. Let's a quick revision here. We have done this, GDD. So, we have talked about Minischen's, Ahmed glaucoma wall, Molteno implants, right? One more if you want to know, even if you don't remember, this has not been asked. This is Bierwelt implant. Again, isme bas both silicone tube and silicone plate. That is the difference. Know it, or I give you the permission to not know it as well. If you don't want to retain it, it's okay. Now, when you talked about MIGS, we've talked about all this. Let's have a look at it, right? So, this is trabeculectomy, creating a pathway here, and this is the fluid. So, let's see this one. This is more better. So, what do you see? This is a fornix based, when it is towards the fornix, it's a fornix based flap which is being created. The Tennant's capsule, this is the episclera. So, this slide is just showing you how the flap of conjunctiva has been created, nothing else. And now see, this was a V-shaped incision given on the base sclera after dissecting everything, and this is the V-shaped incision that is given. What I will do, I will reach up to here after dissecting. So I have given an incision and now this time I am dissecting till here. When I will reach here, what will happen? I will be seeing the greyish tissue which I am going to cut as a block of cut. So this is another way of creating a conjunctival flap which is limbus based. So these are only showing you the different base conjunctival flaps. Limbus waist. Yeah, this is important. As I said, like a blister elevation post-operatively, this is what is bleb formation. This indicates the success of procedure that your fistula is patent. Now see, this is your plate and this is the drainage device. A basic design of a glaucoma drainage device. Okay? So fluid is exiting into the plate. Let's have a look at further. So this is it. See, this is all, this is, the fluid is flowing into the plate here. The arrows are showing you. This is what is Ahmed glaucoma valve. This is your Ahmed glaucoma valve, AGV. Right? Okay. These are Maltino implants. Just remember, these are Maltino. Again with a plate and a tube. This is the tube inside the anterior chamber, if you can appreciate. So this is the tube inside the anterior chamber. This is the eye stent. Just see how it looks like. You don't have to remember everything. See, this is how small an eye stent is when you hold it in your finger. Smallest implant in your body. Okay? Yeah. Interesting. This is the hydrus. See, this design is here, it is implanted in the Schems canal. I don't think they are going to ask you each and everything, but you have to have an idea to retain things. So what was the Zen gel I was telling you? It is like this, see. So clearly shown how a Zen gel implant is placed into the, and then it goes subconjunctival, right? So that was about the treatment of glaucoma, right? Now we are left with a very small topic, but a very important topic here, congenital glaucoma. So give the heading, congenital glaucoma. So when you say congenital glaucoma, we can actually learn it as primary congenital glaucoma or secondary congenital glaucoma. As I have told you earlier also, when we say secondary, it means we know the cause, and primary, we are not sure of the cause. Right? Now, also a few more points here. Where first we talk about, give the heading, primary congenital glaucoma. So primary congenital generally is considered sporadic, okay, to happen sporadic, and if it is hereditary, please remember, if hereditary, it is mainly autosomal recessive. Don't forget, it is autosomal recessive. Another important point, it is more common in males than females. So these are the 1 or 2 points which I want you to remember. Now, talking about how to classify a primary congenital glaucoma, we can classify this as true congenital. True congenital means the child is born with it. Then infantile. Infantile is less than equal to 3 years of age. And juvenile means more than 3 years. So here infant is 1 year, but here infantile means less than equal to 3 years. And juvenile is more than 3 years. Now pay attention. Now let's understand here. In a small child, the sclera is very soft. So whatever pressure is rising in the eyeball is causing stretching of the sclera and enlargement of the eyeball. And this is what is called buphthalmos. Okay? So this is what is called buphthalmos. So what is buphthalmos? It is nothing but enlargement of the eyeball, which will happen when either in true congenital or infantile, but not in juvenile. Then we talk about why it is happening. Apart from this, what can be the pathogenesis? So pathogenesis, mainly just learn with me, there is angle malformation, which we can also call as trabeculodysgenesis. Okay, so trabeculodysgenesis. So because of this, there is impaired drainage, more aqueous, leading to more pressures and glaucoma. Okay? Okay, Barker's membrane was also something I myself used to teach till last year, but again this recently it is said that now it is considered not very important, we shouldn't mention it. Okay? So Barker's has become an old concept, we will not mention it. we come to angle and malformation, or we call it trabecular dysgenesis. So everything is included in that, whether it is problem. Generally, the problem is some anteriorly located iris insertions. Okay, so commonly it is anteriorly located iris insertions. Anyway, once we know what is trabecular dysgenesis or angle malformation, now how this child will present. So that was about patterns. Clinical features. The child presents with watering. Of course, the parents are noting this. Then photophobia. You all know what is photophobia. Intolerance to even normal light is photophobia. And blepharospasm. That is, what is blepharospasm? When the lids are being closed due to this photophobia, we call it blepharospasm. Okay. Now, there has been a PG question about which is the first, which doesn't make much sense. Should I answer photophobia? Some answer watering. I don't want to comment on it. I don't think it will be ever asked anymore. Okay. So anyway, so this question doesn't make much sense actually, and it was only asked once long back. So we'll not discuss that. So what we are saying here is, this is how the child presents. When I examine, what do I see on examination? All of you, how do we learn on examination? In my style, that is, make the diagram and label it. So let's make the diagram and label it. And start thinking from outside to in, all of you. Make the diagram. Okay, so tell me now, what is seen in the eyeball? Do we remember that? Yes. So first write down buphthalmos. So eyeball, buphthalmos. And if the eyeball is enlarging, common sense, cornea is also going to enlarge. And when the cornea is going to stretch too much, there can be break in the Descemet's membrane, which can lead to corneal edema, and therefore the cornea will look white. And later there can even be corneal scarring and vascularization. So how to write it? We will write large cornea because of the stretching, white cornea because of the edema, and the break in the Descemet's membrane is called habstria. Okay, these are habstria. And remember, this scar, it can later lead to corneal scarring, in bad cases, and vascularization. Corneal scarring and vascularization. Hope you've noted down. What is behind the cornea? Anterior chamber. Eye is enlarged, so naturally the anterior chamber will also be deep. What we see in the angle? Of course, some angle malformations, angle anomalies. You call it angle anomalies. Okay, so when the eyeball is stretching, do you realize the distance between the lens and iris is increasing? Support of the lens on the iris is gone and the iris starts trembling like this. And this is what is called iridodonesis, the tremulousness in the iris. We have learned this, or you must have learned it in aphakia chapter also. So this is iridodonesis, which is nothing but tremulousness in the iris. And again, due to the enlargement of the eyeball and stretching, what else you can get is flattening of the lens. The lens curvature is decreasing. And too much of stretching can break the suspensory ligament, and any break here will lead to subluxation of lens. I think you all are now very expert in this. Subluxation of lens. Simple, if you keep labeling like this. And what will you see in the retina? What do you expect? You expect cupping of the disc. But really, just understand this, that when the pressures are increasing, even the eyeball is increasing in size. So sometimes these high pressures may not damage the optic nerve and you may not get any substantial cupping. Okay? But yes, for the sake of completing the list, we may get cupping of disc. Right? If I am getting these things in the patient, how will I proceed next? Of course, I have to examine this child. How will I be able to examine a small child? Under GA. So you examine under GA, but please don't forget, I have taught you this. Under GA examination is important, but giving GA means IOP is lowered. So it lowers the intraocular pressure. So I would like to prefer to measure the IOP in a more sedated but conscious child. Okay, so that is one thing. So try to prefer a conscious sedated child for IOP measurements, right? Anyway, What next? I'm going to see the corneal diameter. I will see all the anterior segment structures, of course, because I will try to check for the findings, but mean is large cornea. So if any corneal diameter, please, this is not called megalocornea. You can write it here. It's a differential diagnosis. The megalocornea is a differential diagnosis. What is megalocornea? When the adult corneal diameter is more than 13, we call it megalocornea. Here, if the child is 1 year of age and I am getting more than 12 mm, this is suspicious. It is significant. Okay. So I am going to see the corneal diameter. I will go for anterior segment examination, right? Detailed examination to see other causes. And of course, I have to go for optic disc to see the CD ratio, cup disc ratio. You already know this now. So any asymmetry I have to check for here. I may find, I may not find. And of course, gonioscopy to see any anomaly in the angle, right? Has to be done, right? So all these investigations or examination has to be done in this child. Okay, so how am I going to manage it? Should we first go to the slides here? Okay, have a look here. This is a child with congenital glaucoma. This was your actually exam slide. Okay, so large cornea, and the history was very, very suggestive that the child has congenital glaucoma. Also remember, it's a small child with watering could also, the cause could be, at your level you should have one very strong differential diagnosis in your mind, and that is nasolacrimal duct obstruction. Okay? Okay, so here I am seeing a clear cornea, but here in this slide I see a hazy cornea as well due to corneal edema. And look here, so this is what is Habs stria. Habs stria, can you see these horizontal lines here? This is line. All this is Habs stria. What is Vogt stria? We will learn in cornea, where in patients of keratoconus when there is a break in the Descemet's membrane. So both are break in Descemet's membrane, but please remember, very interesting point here. Vogt's is generally seen parallel to the steeper axis. This is Vogt. Make the diagram, all of you. This is seen in keratoconus. And what is Habs stria? Habs stria is generally either circular or horizontal like this, as you see in this case. Okay, so these are Habs stria. Let's see the next one. Okay, on gonioscopy, I can see some tuft of blood vessels here, which is called Loch-Ness monster phenomenon. Just know the name. They, again, if you don't want to know it, I'm okay with it. So it's up to you. Right? Okay. But there's no harm. It's a very unique name. You will know it. So it's a feature of congenital glaucoma. Now, talking about treatment. So treatment, this is a very, very important double Q. What is the treatment of congenital glaucoma? You are going to answer goniotomy. Treatment of choice. It's always, especially in primary congenital glaucomas, please remember the treatment is not medical, it is always surgical. And the treatment of choice we will answer is goniotomy. What is goniotomy? So what do you do in goniotomy? It's with a gonio, I'll just show you the slide. You just have to understand cutting through the angle. So I'm taking a knife from one limbus, passing through the anterior chamber, going to the opposite, sweep the knife. You are actually giving incision at the midpoint of the trabecular meshwork. Okay? So this is what is goniotomy. Let's have a look. So see, what you are seeing here, this is the removal of surface. So this is how we are scraping it. So this is your goniotomy, or you can understand from here. Goniotomy knife from one angle, you're going to the opposite, and then you are going to sweep it, create a sweeping movement to cut through and give an incision into the midpoint of the trabecular meshwork. Right? The same thing is shown here. So do you realize when I am going through like this, I have to have a clear cornea to see now. So if I don't have a clear cornea, and if the cornea is hazy or the goniotomy is not successful, my next step is trabeculotomy. Write down all of you. Trabeculotomy. What is trabeculotomy? What am I going to do here? In trabeculotomy, you make a partial thickness scleral flap like this. Okay? And once you make a flap, you insert the trabeculotome into the Schelm's canal. So instead of going through the anterior chamber, through the Schelm's canal, I am cutting through the TM. Let me make your life simple. So what you have to understand, in goniotomy, there was a cut in the trabecular meshwork, correct? But this has also been your exam question. If cornea is hazy, too hazy, or I cannot visualize, difficult in visualizing, my choice should be trabeculotomy. What is this? Trabeculotomy is going through the Schelm's canal after creating a partial scleral flap. From the Schelm's canal, I am cutting the trabecular meshwork. Okay? And then rotating it into the anterior chamber. So trabeculotome entering through the Schelm's canal, rotating into the anterior chamber, making an opening. So this is cutting in trabecular meshwork and Schelm's canal. Going through Schelm's canal. Just remember this point. We are going through the Schelm's canal. And what is trabeculectomy? I have already discussed this with you all. Right? This can also be an option. Now pay attention. If your question is treatment of choice and goniotomy is not in the option, our next best option is trabeculectomy with trabeculotomy. Okay? So remember, it is T&T procedure, we call it. Okay? So this should be the second choice of treatment to be answered in your PG entrance, right? And please keep in mind, trabeculotomy is commonly done along with trabeculectomy. Got it? So that was about the treatment. Okay. So lastly, a little bit idea about secondary congenital glaucomas. What can be the causes? Some important ones that you should know about secondary congenital glaucoma. So first important cause, write down phacomatosis. That is neurocutaneous syndromes. Sturge-Weber, right? So one is Sturge-Weber syndrome. Do you all remember Sturge-Weber? Just simple, it is a triad of hemangioma on the face, which is called nevus flammeus. If you remember, it doesn't blanch. So hemangioma in half of the face. Then just making things simple for you, hemangioma in the brain and glaucoma. Okay, so this is the triad of Sturge-Weber. Have a look. So this is a child with nevus flammeus that we are talking about, that is hemangioma on the face. Second you have to know is neurofibromatosis type 1. So second important cause of secondary congenital glaucoma can be NF1. Please remember this. So when you say NF1, the glaucoma here is generally due to angle anomalies. Right? And it is generally associated with plexiform neurofibroma. You know plexiform neurofibroma, which gives S-shaped lid formation. S-shaped lids. Let me show you. Just these points are important. We'll talk a little more about NF1 in the further chapters. Right? So, this is about NF1. Let me show you this. So, here you are. This is your S-shaped lid due to your neurofibroma. And I hope you should be very, very easily remembering this, that when you talk about the ocular features of NF1, the most common being hyperpigmented nodules that are leash nodules. As I said, I'll discuss further in the further chapters, right? Then there can be also your roof anomalies, roof is defective in NF1. There can be meningoceles, right? Sphenoid dysplasia. So, and what else that you have to know in NF1 is optic nerve gliomas. We will write it further. Let's not write here. It will mix up. Another important cause of secondary congenital glaucoma that we should write here is aniridia. So third very important cause that you should keep in mind is aniridia. So when you say aniridia, actually it's not that the iris is totally absent. A small frill of the iris is still present, which blocks the angle and therefore causes glaucoma. So understand there is a rudimentary frill of iris processes, iris tissue already there. This is mainly the cause of glaucoma. So write down rudimentary frill of iris is present, and this is, so mainly this condition happens due to, it's a genetic condition, and mutation is in the PAX6 genes, mutation in PAX6 gene. PAX6 we are going to learn in our embryology. This is the main gene for formation of the eye. So some mutation in the PAX6 gene is causing your aniridia. And another important point, one variety of aniridia is associated with Wilms tumor. We cannot forget that, right? So remember this. So it may be associated with, I'm making simple, instead of discussing all the types, not needed, just remember may be associated with Wilms tumor. Okay? So that was about your secondary. So there are few more if you want to, I don't think they generally ask about Peters anomaly or so let's not unnecessarily complicate our life. These are the important causes of secondary congenital glaucoma. This should be enough. Okay, so a long journey of glaucoma is finally ended. Thank you so much, and keep working hard and keep remembering, still I'm not discouraged. Keep fighting. Stay blessed.